Well, good morning, everybody. I am Elke Eaton. I am a nurse at University Hospitals of Cleveland, and I am the nurse coordinator for the program that is called Cinema, which I will have to read to you what that means in the future. So what I wanted to do is I thought I would start out with a case study. Oops, you can't hear me. It's with a patient who came to us in the Center for Integrated and Novel Approaches in Vascular and Metabolic Disease. So that's a mouthful, so that's why we call it Cinema. He came to us about 2 years ago, and I kind of chose this person because he demonstrates the issues we are having in this patient population and how we can improve patient care and their overall outcomes. So we have Mr. D here, and we call him Mr. Difficult Diabetes. He is a 64-year-old male that presented to us with poorly controlled type 2 diabetes. He was referred by his primary care physician, and he was diagnosed about 10 years ago and put on a sulfonylurea, which was glibazide. And it was 4 milligrams BID. And then he was just sent on his way. So no follow-up, nobody calling him to see how he's doing. So his diabetes was then complicated by non-ischemic, non-obstructive coronary artery disease, heart failure with mildly reduced EF, hypertension, chronic kidney disease, class 2 obesity, obstructive sleep apnea, tobacco abuse, low health literacy, and he was not technologically savvy. His medications prior to Cinema are as follows. He was on aspirin 81 milligrams, rosuvastatin 40 milligrams, losartan 100 milligrams, and the glimepiride 4 milligrams BID. So here are his lab values when he had his first appointment with us. So he was under the care of several specialists, including his primary care, and this is what we found. His A1C was 11.3, his BMI was 34, blood pressure 142/90, his LDL was 63, his UACR, which we checked, was at 60, his GFR 59, and his LVEF was 45% on echo. His FIB-4 score, which tests for non-alcoholic fatty liver disease, was 1.72, which meant that we needed to look into it. We also at UH have a no-charge calcium score program. So we did a CAC score on him, and it was 785. So now, I want to kind of keep you in mind what he didn't do was prior to this, all those specialists did not do a urine albumin check. There were no retinal exams done within 3 years, and he did not see a podiatrist. So what is our goal for cardiometabolic disease? So our goal is to prolong life, keep the patients out of the hospital and the emergency room, and improve the quality of life. So what Mr. D was not aware of was the risk of what type 2 diabetes can do, and that is to increase his risk of cardiovascular disease and diabetic kidney disease, which we found he had. So this was put together by the International Diabetes Foundation, and it shows what is going to happen with type 2 diabetes globally. In 2017, there was an estimate that 425 million people would have diabetes, and it is projected that this number will increase by 33% by 2045. This is a chart from the Centers of Disease Control in the US in 2020, and it shows that we have a huge problem. So nearly 80% of all adults with diabetes are either uncontrolled, untreated, or unaware. So going back to Mr. D, you can see that he was not very well controlled, and he was completely underaware of having kidney disease, and he was not being treated properly for his diabetes. So Mr. D, like I said before, was seeing several specialists and his primary care for his overall care. Many people have received fragmented and siloed care leading to defects in their care. On average, a person with type 2 diabetes may see 3 to 5 specialists, including their primary care. And this leads to delays in care, leading to inadequate glycemic and risk factor control. Many people also lack the support system for adequate control. So this is how Cinema was born. We were able to eliminate the fragmented and siloed care, instead develop patient-centered care model. So what we have here is you can see that the patient is in the center. We have a cardiologist that is also a diabetologist, and they also look into the kidney care and the liver care. And there is a nurse navigator, which is me, and a diabetes educator, and then there's a dietitian who is also a diabetes educator. In order to become a candidate for cinema, you must be diagnosed with type 2 diabetes or prediabetes and have one of the following. So cardiovascular disease, chronic kidney disease, an elevated coronary calcium score of over 100, and then risk factors for heart disease as well, so high blood pressure, high cholesterol, overweight, or obese. So what are our targets? So it's a reduction in cardiovascular events. So for glycemic control, we'll do lifestyle changes, order medications, and use continuous glucose monitors. For body weight control, similar, but we also added GLP-1. Cholesterol control, we want to maximize lipid-lowering therapies. And for CKD progression, we want to control blood pressures, add an ACE and an ARB, SGLT2s, and a non-steroidal MRA. So this is what the cinema patient workflow looks like. So the patient is referred, doesn't matter who, can be any physician, or they can refer themselves. We receive the individual's referral. We then check out their medical history, see if they meet our criteria, and then we call them and get them scheduled. For the pre-appointment, we'll also order labs, and then we'll also create a personalized treatment plan before they come in. Once they come in, the day of the appointment, the diabetes educator sees them first for 40 minutes, and there's an assessment done. They review lifestyle, diet, exercise, and other factors. They also provide education, and then they'll start the goal setting with the patient. The physician comes in for the next 40 minutes, so it's an awfully long time period with the patient. He also does his assessment or her assessment, patient's medical history, risk reduction strategies, patient goals for disease management, and usage of new medications. And at follow-up, after that meeting, the nurse and the diabetes educator will call them and discuss further steps. So we'll do follow-up appointments, and we'll do education for medication management or any other kind of teachings that they may need, and we will order their lab tests for follow-up visits. We also provide resources for whatever they may need, which we'll go over next. Usually, we do an initial visit, then we'll do a 3-month visit, and then depending on what we order and how they are progressing, we'll do 3 to 6 months. And then eventually, when they meet criteria, they graduate, but they don't really, because they come once a year for an encore visit. These are the education that we provide, and it's all free of charge. Once a week, we have lifestyle education talks, and they're every Monday, and they are on Zoom. We tried to do in-person, but people preferred the Zoom. And then we do a Zoom resistance band class on Tuesdays. We also have a quarterly in-person support group meeting. It's pretty much driven by what the patients want. So whatever topics they want to hear, we'll try to bring in people to talk about it. Last month, we actually had a chef come in and do a food demo, and then they were able to try a different version of food that they might not consider eating. We also did a live exercise class, and then all of a sudden our exercise class boomed, so it was all good. So it's also an opportunity for them to share their personal feelings, any experiences, any coping strategies. There's a lot of talking going on, so it's a 2-hour-long thing. So then we were extremely fortunate from a donor who gave us money to do this. In 2 years, we were able to start a monthly UH Cinema Blockbuster webinar series, and where we had various speakers from around the country on various cardiometabolic topics. So that's actually been pretty nice that a lot of people from all over the country actually come in and listen. So finally, and I never want to forget my pharmacy services, we have an amazing team, and they actually, we came up with an idea to contract them, so cinema does pay part of their salary, and they support us and doing medication counseling, virtual follow-up, medication optimization, prior authorization, financial assistance. They do home delivery, and they contributed to our Zoom calls on Mondays. So here's Mr. D. How did he turn out after 3 months? So his A1C, he went down to 6.0. His BMI went down to 29. His blood pressure went to 119/73. LDL was now 28. UACR is now 31. His GFR went up to 72, which is good for those of you that don't know. LV, his left ventricular ejection fraction also increased. It was 55%, and his FIB-4 score went down to 1.48. So still not perfect, but we're close. So what did we do? So for lifestyle, he decided to increase his vegetables. He was actually Italian, and he ate a lot of pasta and a lot of bread. So we tried to get rid of that. And then we replaced his snack bars with nuts. And then he started an exercise program, 30 minutes daily. We added Synjardy, which is empagliflozin plus metformin combination drug. And we added semaglutide, otherwise known as Ozempic. And then we titrated him off of his glipizide. We also changed losartan to candesartan, and then we're able to titrate it from 32 milligrams QD to 8 milligrams QD. His weight loss, he went from a size 44 to a 38 waist. And smoking cessation, the biggest thing, he quit smoking. He also, mind you, I told you he was not technologically savvy. He was able to enroll in our continuous glucose monitor program, and he also did not know how to use a cell phone, nor did he own one. So we actually, through our program, were able to provide him with a cell phone in order to read the CGM. So how does cinema look like in the future? So this is where we're going. We are now we're looking at housing, the environment that they live in, coordinated care, and affordable care. But how do we do this? Because now this is adding even more on me, right? Don't like that. All right, we incorporated community health workers. So what exactly does a community health worker do? So ours reaches out to the patient for reminder calls for appointments. They coordinate transportation and follow-up after the appointment to see if the patient has any questions. They provide education for the patient, for the patients that have low health literacy. And if needed, they will go to the patient's home and they will help them use technology. If within their scope of practice, they might get vitals, or they might teach the patient how to take their vital signs. So when they come to the doctor's appointment, we know a history of blood pressures. Then also, let's say they have a hospital stay, they'll assist patients with transitioning back to their homes and reducing the possibility of readmissions. They navigate insurance, so helping the patient acquire the insurance and then keep it. And any others, also find out any other services that insurance companies will provide. And then finally, they connect an individual and their families to available resources in the community. So the next wave for cinema, I haven't started it yet, but this is what we want to do, is use technology. So I know, was it Brandon mentioned this, about giving these items to a patient in their home so they can monitor their blood pressure, their weight. They get a smartwatch, they get glucose monitoring if appropriate, and they also get a smart cap on their medications, which tells us whether they've taken their medication. Actually, it's only if they opened it up, it doesn't actually take it in. Okay, and it's connected to a smart hub, which then gets transmitted to us at UH. Currently, I am the volunteer to look at all their things, so all of their vitals and anything else. It does alert us if there's anything out of our criteria, and then they get a phone call at home, and we then can see, if they need further care from us. And thank you for listening to me.
Thank you so much for sharing your experience, Elke, in Cleveland. And now we're actually going to hear about an experience from London. And very pleased to have both Lisa Anderson and Debasish Banerjee. Thank you.
starting off.
Yeah, sorry, it's a double act. It's Dr. Anderson and I. Thank you very much for giving the opportunity. First of all, Nisha and Caroline for inviting us, and the rest of the KDIGO putting up with that in a fantastic place, actually, a nice venue with a casino and everything. Now, what is very interesting is that from what Elke just said and what we heard from Robert and Adira and particularly Brendan laying out, where the evidence is, I think this is quite timely that we talk a little bit about our experience and how cardio, kidney, and now metabolic care has evolved at St. George's. Now, we do have another person, Dr. Mimi Chen, who is not here, who's the metabolic person in our team. But I think we need to acknowledge that our wider team involves all the heart failure nurses like Matt Sunter, the pharmacist Tristan Williams, and the heart failure pharmacist Laura. So there's a lot of people involved in what we do. Here are disclosures. Now, you heard about Mr. DD, the difficult person, but this gentleman was not that difficult, I'm glad to say. He was quite old, 84-year-old, but had a fantastic wife who was technologically very savvy. Now, you don't need to read about all of the comorbidities that he has on the left-hand side, but what is interesting is that we were able to uptitrate and start his medications very quickly. So we started him on dapagliflozin, sacubitril valsartan, eplerenone, and IV iron very quickly within about a couple of months because he took part in a study called the LIFT study. And I'm very pleased to say 2 years on, he hasn't had a single hospital admission, which I remember him telling me in the first day in the kidney heart failure clinic. Now, we talked a little bit about this, that why do we need interdisciplinary care and why do Dr. Anderson and I work together? And all of you know, and you heard from Brendan, that there are lots of barriers to care, and we're going to talk a little bit about that. But we do have enough evidence in this large population of patients where, 50% of heart failure patients do have CKD. One thing we do need to remember, and we're going to talk a little bit about, is what the patients expect. I think Elke did mention about Mr. DD, but a lot of our patients have different expectations. I'll hand over to Dr. Anderson.
So thank you very much. So I'm just going to talk about how I came into this and how I was almost forced into the cardiorenal clinic because I had no other option, not because I had any higher ideals, really. So Deborah and I are really lucky to work at the best hospital. It's not great necessarily in terms of academic or even probably outcomes, but it's a fabulous place to work. We have a fantastic local population with multiple mixed ethnicities, around 20% Asian, around 15% Afro-Caribbean, and a really fantastic staff who work hard despite lots of challenges from the management, who often seem to be helping us trying to look after the patients. So in this area of London, like the rest of London, there was a very steady yearly increase in population in the years running up towards Brexit before all the laws changed. And this was obviously having a big impact on every kind of admission, but heart failure admissions as well, which were just steadily creeping up from around the time that I was appointed until the start of this story. And our hospital is almost like a little city in itself. It's a group of old Victorian workhouses and more modern buildings, all of which are falling down. And we've got lots of wildlife inside the buildings, including foxes. So it's not ideal, but still sort of amazing in the terms of the hard work that the people who work there put in to improve patient care. At this time, I was appointed as the first heart failure cardiologist at St. George's, and it was very much a tertiary cardiology centre. Heart failure patients were not allowed into cardiology. They were unwelcome. So it was very much an interventional cardiac unit, and when you looked at where the patients were throughout the trust, there was only 13% of heart failure patients ever actually made it into cardiology. So we were right down on the National League table, 170 out of 178 trusts. And this obviously with just one heart failure consultant and by this time 2 inpatient heart failure nurses was really a challenge to manage, particularly as the bed space got more difficult and length of stay went right down because patients were being discharged too early. So we have fantastic commissioners who backed both myself and have backed Debu in the cardiorenal service, who approached the trust to provide a sequin, which is Care Quality Improvement Initiative funding to develop a heart failure unit within cardiology. And this was not a popular idea. Heart failure does not make money. Why on earth would the trust want to start building a space for heart failure patients? So the commissioners had to keep on increasing the amount of offering until it got to £1.2 million, at which point the trust caved and agreed to do it. But unfortunately, like any change management, when you try and force somebody to do something, they can really make it very difficult. So despite the fact that this large amount of money meant that theoretically I had a fantastic therapy team, a pharmacy team, and junior and senior fellows and everything to look after our heart failure patients, nothing actually happened. And this money was meant to be spent in the 14-15 year. By the end of that year, absolutely nothing had happened and none of the money had been spent. And actually, what I wasn't really aware of at the time is it was all money going into trying to shore up the financial circumstance of the trust so that we could get foundation status, which we did get, thanks to partly to our sequin funding for the heart failure unit. But obviously, when you're in this situation, you're trying to cover up lots of financial holes. It didn't last very long, so we became a foundation trust in the February of that year. By the end of that month, it was clear that we were on track for a massive deficit and a huge deficit the following year. So things were really difficult, and trying to get a new unit through in that situation, you can imagine, was very difficult. But the commissioners stuck by us, and they put another £250,000 in later on that year. And we did finally get a business case approved for a 3-month pilot. And in that 3 months, which was meant to start in the January of 2016 till the end of the March, I had to set up staff and also show that it was businessly, it could meet ends during that time, and it didn't cost the trust any money. At this time, we then would taken over because we were in such financial difficulties in the trust. So there was no wriggle room here. You know, I absolutely had to not only get this going, but also make it financially balanced. And, you know, it was really difficult. The commissioners eventually had to put a contract performance notice on the trust to force them to actually help me and open up the heart failure unit. So we got our funding approved, we began the building work in the January, we opened the heart failure unit in the February. Of course, none of the people who'd been recruited had actually arrived, so we had 60% vacancy. So I was really in a very, very difficult circumstances, and I needed help. And I needed a nephrologist to help me with those patients that come in that's 35 kilos over a GFR of 20, who you can, like, they can take a bed for a good couple of months if you're not careful. And I needed a nephrologist to help me so I didn't get into those difficult situations. And I needed to try and get sort of every bit of money count so that we were allowed to go through, because just as I was setting this up, I was also being taken to this thing called the IDDG every couple of weeks, which was the Investment, Divestment, Disinvestment Group, who were looking at our finances. And they did at one point threaten to take the whole thing away. So anyway, with Debu's help and lots of other people's help, we managed to float the heart failure unit. It's now in place and it's no longer sort of under attack. But we started working together a lot closer when we started doing the cardiorenal clinic, which when Debu suggested it sounded like something I needed, like a hole in the head. You know, I was fighting so hard to try and do one thing, and to do an extra clinic once a week was just seemed like really a difficult thing to do. But I needed his help for my inpatients, so I was sort of agreeable, and we went along. And when we started working together, one of the first things that we did was look at our heart failure admissions and what had been happening with them. And this was a look over around 1,000 patients. We have to put everything into a national heart failure audit in the UK. And not surprisingly, really, you can see that the blue is CKD 1 and 2, orange is CKD 3, and the grey is CKD 4 and 5. And not surprisingly, you can see this drop-off in treatment levels. When you look at just the ACE inhibitors, you can see how profound this is. And for CKD3, we really shouldn't be that cautious. But in the same paper, we looked at outcomes, inpatient mortality. And you can see that with CKD, there is a kind of a gradient of risk as CKD goes up. But something that really, really shocked me and did actually immediately change the way I worked as a heart failure specialist was this gradient of AKI risk. So the national mortality in the UK for acute heart failure inpatient mortality is about 10%. And if you can kind of slide through your admission without an AKI 0, that halves your inpatient mortality. Whereas if you have just AKI 1, you can see that it's 20%, so you've quadrupled inpatient mortality just going from AKI 0 to AKI 1. And if you go to AKI 3, that's almost 50% inpatient mortality, 10 times the risk of somebody without AKI. So that really made me very, very alert to AKI, and it's always something that I've really trained the junior doctors that, this is like major alarm bells. AKI 1 is really serious business, and you have to try and work out what's going on. If you think there's any chance of sepsis, get in there really quickly and treat it, and just try and tide the patient through what could be a very stormy period.
Thank you very much, Lisa. So this is 2016. Lisa's unit has been established, and I was helping him with the AKI patients. But I wanted to set up something in the outpatients area, and I'm very pleased to say 2017 March, we set up the cardio-kidney clinic, which Lisa and we started off together. Now, we had to present some data to the commissioner saying that why is it going to be useful? And not exactly this data, this is Dr. Bansal's data showing, and I take no shame in showing this once again, because from the hands that went up of when we were asked how many cardiologists measure USCR, this is very important. USCR means bad. And not only that, if you think about USCR and treat it with this simple SGLT2 inhibitor similar to what Brendan had already shown, it does help. So doing albumin-creatinine ratio is very useful. And as a kidney doctor, if you look at all the trials that we have seen, CKD patients, at least 3B patients, which again, Brendan showed quite a lot about, do get help. But how do we do in general practice, in primary care? I'm glad Richard talked about primary care. We don't do very well. And this is data from Dr. Sarah Visi, Swedish Heart Registry, and you can see stage 3B patients with triple therapy. This is excluding SGLT2 inhibitors. You've got only 19% of the patients actually having that. So it's quite bad. The other thing which we realized in the cardio-kidney clinic very quickly is this frailty as a problem, and that changes patients' priorities. A frail patient thinks completely different from a non-frail dilated cardiomyopathy patient who is young. And what we realized very quickly, and this is one of the analysis by Dr. Butt, you can see from the Deliver study, that frail patients on your right-hand side can be older, obviously more frail, have a lot of CKD, but they do get the same benefits, perhaps a little bit more as a person from the cardio-kidney world. So yes. The other problem that we had to deal with in the cardio-kidney clinic, and I'm sure we'll talk more about this, is hyperkalemia. And you can see this is a very nice database of emergency admissions from Canada. And you can see as the GFR goes down, the incidence of hyperkalemia in the emergency admissions is going up quite steep. So that's another problem that we learned that we need to manage in the cardio-clinic clinic. The other problem that we learned very quickly was this fluid overload. So when we analyzed our patients in the cardio-clinic clinic for 3 years, we saw that in the 318 patients over a median follow-up of 443 person years, there were 201 fluid overload admissions. So the question is, what can we do about them? So remember these barriers that we are constantly facing in the clinic. Now, one thing, and you saw this from Elke's slide, is that there is a lot of people involved in their care, and sometimes that confuses the patient quite a lot. And in United Kingdom, the general practitioner holds a lot of that together. You know, they prescribe the medications, they do the regular prescriptions every month. So all of these people need to work together to make sure that the patient doesn't get confused. And the patient should be at the heart of care because their priorities can be very different. So on your left-hand side, that elderly lady who may be 80 or 84, she's only thinking about spending the rest of her life without having a hospital admission and maintaining quality of life. Whereas a young person, you know, a young lady here, as an example, with dilated cardiomyopathy, is thinking how she's going to bring up her child. And, you know, she has to live long, so we have to think about that. So in the interdisciplinary care, what we do is we have a very coordinated approach. So we think about the patient first and then personalize the care and the optimum care, which is very important. Not everything will be for everybody. But one thing we are realizing more and more in order to deliver this GDMT together with diuretics and IV iron is that we need to think about variability of care in our population. We have responsibility for the entire population. So Lisa and I, we have a responsibility for entire Southwest London and how we're going to deliver care there, and Lisa will talk about it a bit more. Obviously, it requires multidisciplinary approach, and it requires close monitoring. Now, the next slide, I'm just trying to show you that we do have some protocols that we follow in these clinics. You don't need to read about this. And if we do follow these protocols, we do see some benefits. So this is the first year, so 2017-2018 data of our first 127 patients seen in the clinic. And you can see that even with one visit, you can do things better. And Elke showed you Mr. D, where things really improved over time. One thing which we have learned, particularly with this study, which is the LIFT study, where we have been taking these patients who are quite old. The mean age in this study, which has already recruited 104 patients, is around 75. You can keep increasing their medications every 2 weeks, provided you provide that care where you monitor them. You monitor their blood pressure, examine them if they have fluid loss, if they're having diarrhea, etc., and titrate the RASI. The other thing that we have done in our locality is try to tackle the subcutaneous fluid overload. So this was very kindly funded by the Southwest London NHS Innovations. And we could treat these patients who have kidney disease and heart disease who are about to have fluid overload. Sometimes they presented to the accidents and emergency, and I took them from there and worked with the hospital at home team, which is a team in Wandsworth who can see these patients every day if needed at home, and we could keep most of the patients out of hospital.
So just to wrap up, really, future projects. This is our next funded project. It's a cardiorenal metabolic clinic. NHS England has identified that there's a growing demand for renal services, particularly due to dialysis. And they want to really, now that we've got drugs that can reduce this, they want to get in there and change the projections. So NHS England has put funding into all of the ICBs, which are the sort of divisions of healthcare organisation around England, to promote prevention and better management of CKD to prevent the large numbers of patients going on to dialysis. And in our area, there's a project with GPs, getting GP practices trained up in testing for proteinuria, in getting patients on SGLT2 inhibitors in addition to RAS inhibitors. And there's also a project about end of life, making sure there's better palliative care for the patients where there's a choice between dialysis or supportive care. And then our project is the Cardiorenal Metabolic Clinic, where we'll be working with our colleague, Mimi Chen, and we're lucky in London in that data is all shared. So we've got our ICB, we've got a data sharing agreement, and we've pulled all the patients out of our local sector of London who have combined diabetes, CKD, and heart failure, plus or minus obesity. And we are going to be approaching this in a sort of semi-academic way, having some areas where we're going to be doing the intervention and some areas where we're not. And we're going to be managing this by giving management plans to the GPs and then following that up with pharmacy phone calls and liaison with a GP pharmacist to try and get patients on best preventative medicine. So this is a preventative project in the community, and we're hopefully going to have some data which will show us what happens in our intervention areas and what happens in areas where there's no intervention. So this you can just about see Mimi Chen in this picture here. This was her opening up the cardiometabolic clinic at St. George's in September 2020, so it's quite an achievement opening anything at that point. Managed to drag our chief executive out of hiding to do it. Anyway, so yeah, thank you very much for listening. It's definitely a work in progress. I have learned a huge amount. I didn't know how much I didn't know before I started this, and I also had no idea how you could get really frail patients with CKD rapidly onto medications, and then they'd still be on them a year and a half later and out of hospital. It's been an absolute eye-opener to me, so I would really sort of advocate working with renal physicians. I've been very lucky. So thank you very much.